30-year-old female, tonic-clonic seizure during sleep on May 26, 2010. And she underwent stereotactic biopsy on May 27, 2010 in another hospital. And histology was grade 2 astrocytoma. But she continued to have daily simple partial seizures, intense salivation, numbness, and tingling on the left side of her body. And this is her preoperative MRI. We can see here that there's a tumor occupying the temporal lobe, not only the pole, but also the middle part of the temporal lobe. And also probably also the region of the amygdala, the uncus. And see here, this is a temporal lobe, and this is temporal lobe plus insula. And we can see here that the tumor occupies the entire insula. And in this cut, coronal cut, we see that the temporal lobe is occupied by the tumor. This is Sylvan fissure. And my question is, what is this triangular shaped area? Is it frontal? Is it insula? What area is this in the coronal cut? This triangular shape depicts exactly the shape of the anterior surface of the insula. So that's why it is triangular shaped like this. My question is, what is this tiny structure over here? This is optic tract. This is another optic tract. So if you trace a line from the superior limiting sulcus of insula, there is a straight plane between the upper part of superior limiting sulcus of the insula down to the optic tract. So we decided to perform the extended Terriona approach. So here is the skin incision. It's kind of weird because the incision for the previous biopsy was here. So I just made it one incision. And this is the exposure after the dura opening. This is the right frontal lobe. This is the right temporal lobe. This is a parietal lobe. This is a Sylvan fissure. So let's do the video. So this is a right extended Terriona approach. The first step is to release CSF to relax the brain. So the basal cistern has been opened to release the CSF to relax the brain. And then I'm starting to split the Sylvan fissure. You can see the tumor here over the insula. I'm just placing gel foam to keep the open space, already dissected fissure open, the space open. So I figured out that the Sylvan fissure was very tight. So why not make debulk a little bit of tumor from the temporal lobe, so can create more space for me when I dissect the Sylvan fissure. So not just the removal of the tip of the temporal lobe with the tumor. This is we call as a subepial dissection, where peeling the brain off the arachnoid, so keeping all the veins and arachnoid and arteries intact. So this is and removing still the temporal part, keeping intact. This is the anterior carotid artery, okay, and then this is our optic tract. Anterior carotid artery is over here. And this is opening of the temporal horn. We know that by looking at the MRI, hippocampus is not there's no tumor over the hippocampus. This is peduncle. This is a brainstem, and removing the medial part of this is anterior carotid artery. This is the midbrain. And now, with the temporal part of the tumor removed, and going back to the basal cistern And then now I'm removing the already exposed insula. You see the tumor. Now once again it went back to the temporal lobe to create more room. Now I'm dissecting the anterior limiting sulcus of insula. So if you want to remove the tumor from the insula, this is a gel foam. So I dissect, keep the space open. I insert some gel foam because you will not get stuck. So I'm dissecting. Now I'm dissecting. This is the inferior limiting sulcus of insula, anterior limiting sulcus of insula, and this is superior limiting sulcus of insula. So I have the limits of the insula established. Now it's time to go inside. So you coagulate first branches from the MCA that supply the insula, small branches, not the big one. Big ones you have to preserve. So you sacrifice those small ones going to the cortex of the insula. So this is M2, main branch of the M2. So removing the tumor is very soft. The removal is anatomically based. So we are removing by suction tube. This is the anterior limiting sulcus insula. So actually now I'm working on the anterior surface of the insula. Removing using suction tube. For an insular tumor, we always have to work in between the branches of the MCA. So we're making, this is an ultrasonic aspirator, and then I'm using again the suction tube, and then in the end, after the removal of the insular tumor, you're gonna find white matter. That's what you expect to find. You don't expect to find lenticular artery. If you identify lenticular artery, you have gone too deep. So after the removal of the insular tumor, what you'd expect is to find white matter. So dissecting carefully between the branches of the MCA, you have to keep them intact. And what is the posterior limit of the insula? Posterior limit of the insula is located between the junction of the hasal gyrus and the postcentral gyrus. Hasal gyrus, postcentral gyrus. So you see, after the removal of the tumor, what you see is the white matter. So this is a post-op. Obviously, I will remove all the cottonoids. So this is aspect of the tumor after the removal of the tumor over the temporal lobe and also over the insula. And once again, here is the preoperative MRI with the tumor in the temporal lobe and the area of the uncus, and occupying also the entire area of the insula and the anterior surface of the insula, but does not go to the temporal horn or does not affect the hippocampus. And this is the post-op MRI showing the total removal of the tumor in the temporal lobe and also in the insula. And this is the coronal cut of the postoperative MRI. She remained neurologically intact and seizure-free after the surgery. The histology was oligodendroglioma grade 3, so she underwent chemotherapy and radiotherapy. The last time I saw her was 2019, and she was normal neurological examination, no tumor recurrence, and seizure-free.